The major mood disorders, the major ones that we have are major depressive disorder, a number of other depressions like depression not otherwise specified, and bipolar disorders. So the most common one we have is depression. Depression is an incredibly common issue. I had mentioned before that 1 out of 4 women and 1 out of 6 men in the general population will have a depressive episode at some time in their lives. And we're not just talking a couple, 3 days of feeling really down. We're talking 14 days at least of the person having a significant set of symptoms that interferes with their functioning. And antidepressants are one of the most common things that we give for people who have depressive episodes. So keeping also in mind that people who have developmental disabilities are more likely to become depressed than people who don't. So we're talking a great number of people who have developmental disabilities who can be exposed to a depressive episode. It's called the common cold of mental health issues because it's so common, and it's even more so for people who have developmental disabilities, as I mentioned. So before I go on to bipolar illness, let me just talk a little bit, and I'll even back up, about what does it mean to be depressed. If you're somebody who has a couple of bad days, not a problem. It's just something you have to learn how to cope with. But if you have a depressive disorder where you start to have trouble sleeping, trouble eating, trouble, and by trouble sleeping I mean you're just not getting much sleep, you have what we call high sleep latency, where you will try to go to sleep, but you're not getting to sleep. A normal sleep latency time interval is 40 to 45 minutes. So if you're falling asleep in a half an hour, it's like, yeah, great, you're good, you're healthy. But if you're taking 2, 3, 4 hours of laying there and trying to get to sleep, that's too high. It's it's a signal. All by itself, it doesn't mean anything. It might just mean you're very stressed, or you're coming down with something, or you've got money problems, or something going on. It doesn't necessarily mean depression by itself. But something else that happens with depression and sleep problems is that around 3:30, 4 o'clock in the morning, your cortisol levels change in your body, and you have what's called early morning awakening. And you just wake up, and you can't get back to sleep. Now, if you got to sleep around 1 in the morning, after laying there for 3 hours, you go up to bed at 10, you finally get to sleep at 1, and you wake up at 3:30, you are not going to have enough rest on board. And that's one of the most common constellations of sleep problems that we see with depression. The other problem with depression is people are sleeping too much. They're sleeping 14, 15, 16 hours a day. But the kicker is that they're waking up tired. They do not feel refreshed from having slept that long. Every once in a while, we'll get a good 10 or 12 hours of sleep, and it's like, that was great. Haven't had a chance to do that in months. And we feel better from it. Or you take a look at adolescents. Teenagers need a lot of sleep, and their circadian rhythm is a little different. It's tipped in a slightly different way. So they need a little bit more sleep than we do. So if a teenager is sleeping 14 hours a day, but they wake up refreshed, then it's not a symptom of depression. So if we're talking about somebody who has, for at least 14 days in a row, trouble with their sleep, too much, too little, trouble with their eating, they're eating too little, these people I don't understand, or they're eating too much, and usually what they're eating too much of are beige things like cookies and pie and candy and cake and mashed potatoes and gravy and macaroni with white cheese, or something that's very carbohydrate filled. And that tends to be very common for people who have depression. Not enjoying life, taking something that you used to enjoy, and now you do not enjoy it. You do not have any enjoyment from it whatsoever. And there are different kinds of depression. There's 3 different kinds of depression, and one of them is very intuitive. Somebody is feeling very sad and distressed, and they're upset, and we can get that. It's, they're sad, they're crying, they're depressed. But there are two other kinds of depression that frequently get missed. They don't get diagnosed as often, and the longer you have any psychiatric symptom without treating it competently, the longer it takes to try to address it, the longer it takes to ameliorate. And those are anxious depressions, where the person is so anxious and they're kind of moving and discharging energy, but they're not getting anything done, and they have this theme to what's going on with them, that they're just stressed, but it's non-functional, and it's not like they're motivating themselves to go do something that they're nervous about. They're just nervous. And that's an anxious depression, and we treat that a little bit differently than we do a sad depression. And then the least common diagnosed, but I'd be willing to bet it's far more common than people would say, is an irritable depression. Because typically as social beings, if we have a superficial relationship with somebody, you pass them in the hall and you say, hi, how you doing? Or you say good morning to somebody, and all of a sudden they say, what's so good about it? And they're ripping your head off if you ask them a reasonable question. And it's not just 1 or 2 days of that. It's day after day after day, and it's different from who they were. It's an irritable depression. And again, we treat that a little bit differently than we do a sad depression. The medication is different, the talk therapy is different, and the treatment for depression is typically an antidepressant, but it also can be an anti-anxiety medication if it's an anxious or an irritable depression, or it could just be talk therapy. And many people who have developmental disabilities respond beautifully to talk therapy, cognitive behavioral therapy. And it's something that a lot of research has been done on. It's a very competent approach. You don't necessarily have to go to a medication. The reason we frequently do is that we need to address the symptoms quickly, and sometimes talk therapy is more time-consuming. It can take 4 to 6 weeks before you might see a response, where with an antidepressant, especially the more recent ones, you'll see a response within a few days to a week. So when somebody has depression, because it is so common, it's something that we need to pay attention to and get it addressed as quickly as possible, and try not to respond to any stigmatizing frameworks that people have. Many times I have heard from other clinicians that of course this person who has autism has depression because their life is very difficult. They have a disability that's interfering with their functioning, and so of course they're depressed. No, depression is not a normal reaction to stress. Depression is a standalone, separate problem, and it can be treated separately. There's no way I can take autism away from somebody, but I can teach them how to cope with their symptoms, and I can teach them how to live in the world where their quality of life is better. And the people who are around them can be taught how to manage this particular illness. But depression is special. You need to have it addressed, especially if there's lethality issues, then you just have to get right into the medications. But if the person is able to learn, and just about everybody is able to learn to a certain extent, we want to be able to teach people who have developmental disabilities how to take care of themselves when they're prone to depression. This is just like if you're prone to diarrhea, or if you're prone towards high blood pressure or diabetes. You have to learn about rest, you have to learn about your symptoms, you have to learn about your illness, and you have to learn about depression. If you're a person who is prone to that, you've got to take care of it. So therapy, talk therapy, can be enormously helpful, even in conjunction with an antidepressant medication. And it can last a reasonably brief period of time, or it can be more durable and supportive in nature. Well, that's not what I wanted. So let's talk about bipolar disorder. The layman's term for bipolar illness is manic depression, and which is fairly apt because it is a digression from a normal mood state that is in a polar opposite direction, bipolar. It can go too high, where the person is manic-y, or it can go too low, where the person is depressed. So manic depression is not an inappropriate term, it just doesn't happen to be the clinically appropriate term. An estimated 5.7 million Americans have BPI, And keep in mind that it happens 2 to 3 times greater in people who have any cognitively impairment diagnosis. Anything like that is going to increase the chance that the person is going to have a mood instability problem. And with a mood instability problem, you're going to have complications. The person is going to be burning off more energy. If they're manic-y, they're going to be having sustained depressive symptoms. Most often, people who have bipolar illness have depressive symptoms. Very seldom do you have a problem with mania being on a sustained basis. These are the manic symptoms abbreviated. They're called DIGFAST. It's a fairly apt acronym, but it's the best I could do under the circumstances. And it stands for distractibility. So the person is not going to really be able to pay attention to something for very long because they're up and moving and paying attention to 16 things at the same time. It's not the same as attention deficit disorder. The distractibility level is different, qualitatively and quantitatively different. There is usually insomnia, that's what the I is for. A person can be up for 3 days, not tired, not sleeping, but not tired. Somebody who has attention deficit disorder usually doesn't have a sleep disorder. They go to sleep. They might be up at different hours. They might have some odd hours, but they rest. They get the rest that they would normally get. The G is for grandiosity. The person has an inflated view of who they are and what they can do. So they might feel richer, smarter, sexier, more powerful than they really are, and that grandiosity can reach a level of delusion. Usually when people who have bipolar illness are delusional, it's a delusion of grandeur, where they think that they have some special title or some special skill, or they're famous in some way. Flight of ideas. Ideas come into the head very, very fast when somebody is having a manic episode. And at first it can feel invigorating and exciting and interesting. So this person has all this coming in. But in my experience, people who have a lot of intellectual challenges find the flight of ideas overwhelming at a far lower level than people who don't have a developmental disability. So the flight of ideas doesn't have to fly all that fast in order to be a real problem. And frequently what happens with people who have bipolar illness is that when the mania, when the manic episode starts to get out of control, that where they're not able to catch up with the thoughts and they're not able to really manage their thinking, what they'll frequently do is drink alcohol, and it's usually vodka, to cut off the top of that manic spike because it's so uncomfortable. But the problem is that anybody who has any major mental illness is not going to be able to handle drinking or drugging as somebody in the general population would. And you know how difficult it is for people to stop drinking and drugging in the general population. But somebody who has a major mental illness has neurological and neurotransmitter problems that are different. It metabolizes drinking and drugging very differently than people who don't have any problems with their neurology and with their pathology. So drinking even a very little bit of alcohol to try to squelch the peak of that mania can actually propel that person down into a depression, because alcohol is a depressant and the person is unstable in their mood. So even though they're manic, they either can be shoved, pushed, propelled down into depression or into a mixed episode. A mixed episode is where the person has a lot of manic energy, but they have a lot of negative, depressive, helpless thinking behind all that energy. So a mixed episode might sound like, this is a terrible world and it's awful in the world. The future is just terrible and it can't be done like this and I can't allow this to happen and I need to take all my power and all my money and change that. So there's this depressive streak through all of their ideas, and it's very energized. And that is a big problem, whether the person is diagnosed with mixed episodes or whether they have generated a mixed episode by using alcohol or a stimulant of some kind when they're in the manic phase, because the individual is not going to be able to process the information well. So it is a pretty serious problem, and that's usually when it kicks in. People don't usually drink or drug when they're feeling wonderful, fabulous, smart, rich, beautiful. They don't want to lose that, so they're not going to do anything to get rid of that. And they're not going to do much about distractibility, because they're absorbing what's going on around them, and they actually feel quite stimulated. But it's usually the flight of ideas where people will try to stem the tide because it's so uncomfortable. They're physically agitated. They're going to be moving around very quickly. They're not going to be sitting and holding still. And if you have somebody who has manic symptoms and they have some mobility problems, they're going to have mobility problems with whatever mobility aid they have in place. So if they have crutches, there's probably going to poke somebody with them or swing them around in some way. And if they're in a wheelchair, they might ram people. There's going to be an agitation component to their movements. The speech is remarkable when somebody is manic because they produce a level of information that is likened to a fire hose. It's too much information, too fast, at a very large volume of words. So it's hyperproductive and very voluminous. So you'll be talking a lot and talking very fast. Now, I don't have hypomania listed here. Hypomania is a low level of mania, a low level of manic symptoms. And hypomania, the person might just be talking a little fast, and they might have a little overproductivity to their content. So you might be talking to them, if you've ever had this happen in a personal situation, you're talking to somebody who's talking a little too fast and at a little higher level than what you're used to processing. And you might think, boy, this person is really smart, and I'm just not smart enough to be in this conversation with them. And I'm here to tell you, don't do that. Just automatically think, I wonder if they're hypomanic, because that speech is kind of remarkable in that regard. And then the last piece, the T in dig fast, is really thoughtlessness. But a more appropriate word, more apt word is impulsivity, but dig fasty doesn't make any sense. So the person can't think about the next logical steps to a process. They're thoughtless in that regard. They just, something comes into their head and they do it. They're impulsive in that way. Now you have this layered on top of somebody with a developmental disability who already has some impulsivity issues, and it's going to ratchet to a pretty high and problematic level. So those are the major manic symptoms. There are others. Hypersexuality, but that doesn't fit into my abbreviation, where people will consciously and not in a psychotic manner have indiscriminate sex. And they feel terrible about it later when their manic symptoms start to normalize. But they have a great deal of difficulty with the fact that they did that, but they're compelled to seduce and compelled to be seduced when they are in a manic phase. So there are a number of other symptoms. Oh, that's nice. PowerPoint has such wonderful and thoughtful features to it. So this is what we do to pharmacologically address what happens with bipolar illness. And as I mentioned before, 99.9% of people who have bipolar illness need to be medicated. There is 0.1% of people with bipolar illness can manage themselves on an extraordinarily strict regimen of sleep, rest, activity, diet, and structure. And there are a couple of organizations, don't have many people in them, but people who feel very strongly that they don't want to take a mood stabilizer, more because they don't want to lose the feeling of feeling good and wonderful about themselves and their skills, not necessarily wanting the mania, but they want to have that. that good feeling, and when you take a mood stabilizer, it can be very dulling. So we'll talk about some of the effects of and side effects of mood stabilizers. But an important consideration is that the vast majority of people need to be on a mood stabilizer, and the mood stabilizers we have right now is an old standby lithium, and that's been around since the middle of the last century as a specific pharmacological value for people who have bipolar illness. And it's a little tough on the kidneys, so when you finally get somebody to take lithium, it might happen that in their middle years or when they're a little older, they have to go off of it because their kidneys are challenged by this lithium. Lithium is basically a salt. It's natural. We all have lithium in our bodies. What's interesting is that people who have bipolar illness have exactly the same levels of lithium in their system that we do, the people who don't have bipolar illness. And so it's not that they have a deficit of lithium when we're trying to replace it. It's that the lithium has a calming feature, and it's pharmacologically and pharmacokinetically. It's a very interesting process, and we're not exactly sure how it works. It's some pretty good ideas. That's the major treatment and has been for decades. We found out quite by accident when we were doing research on Clozaril that anticonvulsants, some anticonvulsants, have a mood stabilizing feature to them. And the accidental discovery of this, and clinically there had been a lot of empirical evidence. Clinicians had been saying, listen, when I put somebody who's bipolar on an anticonvulsant, if they have a seizure disorder, and not Dilan, there's only certain anticonvulsants that have mood stabilizing features to them, but there would be some anecdotal evidence that these anticonvulsants were stabilizing people's moods. But when we were doing the research in the United States in the late 80s on Clozaril, a side effect of Clozaril at the higher doses is a seizure disorder or an occasional seizure. And so to anticipate that and to be proactive and prevent a seizure from happening, people in research, at least at several research sites that I know about, they were put on anticonvulsants proactively when they hit the higher doses of Clozaril. And we noticed that their moods kind of evened out a little bit. So that was the instigation for doing specific research on mood stabilizing features of some anticonvulsants. And then for many years we've had atypical antipsychotics that have been used as mood stabilizers, and several of them were designed specifically to have an impact on the mood as well as having an impact on psychotic features. But bipolar illness is so specific in that it can interfere with somebody's logic and the way they process information and the way they interact with other people, that there are a lot of similarities to how the drug can really help them. So atypical antipsychotics are also considered mood stabilizers in many regards. We used to add Haldol to lithium in years past, mostly before in the 70s and 80s, when somebody was having particularly a grandiose delusion that was interfering with their functioning or putting them at risk in some way. And the Haldol can be difficult because of the side effects, especially the extrapyramidal side effects. Makes people feel uncomfortable and they don't want to take it. But the atypical antipsychotics have fewer side effects and they're more manageable. So that's something to keep in mind as a mood stabilizing feature. The general rule with mood stabilization, as it is with any major mental illness, is to start maintenance on the mood stabilizer earlier, and that will predict greater improvement in general, because the degradation of these major mental illnesses on the brain is supported and it's arrested to a certain extent. It's kind of like if I broke my leg and you put a cast on my leg, and the cast would extend to the joint above and the joint below the break. The cast is just holding the bone in position so that it can heal. The cast does not heal anything. It just interferes with anything throwing that bone out of alignment so that the bone has a chance to re-knit and to heal. The medications for major mental illnesses do the same thing. They're neuroprotective. They help the brain to stabilize while the brain can heal itself. And it can take quite a long time to do that, but at least the brain is not being so negatively affected by the illness. So I have to say that any of the psychiatric medications for a major mental illness is approximating what's going on in a brain that does not have these challenges to it. Neurotransmitter function is very complex. We don't have a lock on how all of these dozens of neurotransmitters work in our brain. And our brain is chemically functional, electrically functional, and electromagnetically functional. It has many different ways of working. That's why electroconvulsive therapy, even though you don't convulse anymore, and transmagnetic treatments for depression are so very effective because it addresses other ways that the brain works. The brain works by electrical, chemical, and electromagnetic fields. And when we do a chemical addressing of a problem, we're saying, all right, we think these neurotransmitters, norepinephrine, serotonin, dopamine, we think these are unstable. They're not at the levels they need to be, but they're also not at the levels they need to be in different parts of the brain at different levels. And getting a medication that's going to address that level for, let's say, dopamine. If you have too much dopamine right in the center of your brain, one of the oldest parts of your brain, you're going to be psychotic. You're going to hear things that aren't there. You're going to see things that aren't there. You're going to believe things that aren't true. You're going to be delusional. You're going to hallucinate. That's because you have too much dopamine there. You don't have enough dopamine in the newest parts of your brain, the part of your brain right behind your forehead, where you logically organize information and you process and you decide what to pay attention to and what to ignore for the time being or what to put in the background for the time being. You need a certain amount of dopamine to do that. If you have too little dopamine, you're not going to feel good. You're not going to be motivated. You're not going to be able to function very well. You're not going to talk the way people who don't have these problems speak. So how do you get a medication to give you less dopamine in one part of your brain and more dopamine in another part of your brain? It's very complex. So just something to keep in mind when people are so frustrated about psychiatric medications not working well. It's really an approximation of what's going on with our normal neurotransmitters. And when any of our neurotransmitters is out of balance, putting it back into balance in a chemical way is very challenging. Sometimes we hit it and we get very lucky, but sometimes it's just an approximation, and the rest of it has to be taught, and the person just has to learn how to deal with that as best as possible. It's kind of like taking somebody who has diabetes and they're insulin dependent. And the insulin, while it is a natural product and we can approximate the insulin beautifully, it might not completely control their diabetes. They still need to learn about their behaviors. They still need to learn about when to get some rest and when to be active and what to eat and what not to eat and when to eat and when not to eat. So it's not so much the interactions with other people, that's where the major mental illness interferes, but it gives you a clue as to how very complex any disease process is. And I think psychiatric illnesses really layered on top of developmental disability can make it much more difficult. So we want somebody to be stabilized on their mood stabilizer in a very reliable way as early as possible. So we want to be able to also detect if they're starting to come out of balance. Let's say they've been on a mood stabilizer and they've done fairly well for a certain period of time, but they've had an extra stressor or their body has just changed in some way. They've gained 10 pounds or they've lost 10 pounds. And it changes what goes on with their body. Or somebody made them pickles and they're on lithium, and lithium is a salt, and pickles have a whole lot of salt in them. And so the person ingests all these wonderful pickles that somebody made for them, and it throws off their salt balance in their body, and all of a sudden their mood is different. So you need to pay attention to early changes in what's going on with their mood so that you can quickly quickly try to correct or the prescriber can quickly try to correct their brain chemistry to the extent possible. So you want to make sure that they have access to something that's going to help them. Let's see. I wanted to just make a comment about a couple of the mood stabilizers. As a clinician, you know, all of you have had these experiences, and I understand it can be very frustrating. But when we put somebody on certain mood stabilizers, especially the AEDs, like Topamax or Lamictal, we have to start the dose very low, lower than would be effective for managing their mood. And we have to change the dose very slowly and gradually titrate them up into a higher level, a higher dose level. Because, for example, Topamax, one of its nicknames, a clinical nickname is Stupamax, because if I give you too much and I raise it too fast, I can drop your IQ by 5 points. And that's not something that anybody really needs. You need all the cognitive power you can have to deal with your major mental illness, but also somebody who has a developmental disability really doesn't need another challenge like that. So we want to pay attention to how these medications can take quite a long time to reach a therapeutic blood level. And in the meantime, the person's not going to be very stable. But one of the things I wanted to comment about it is that many times people who are on a mood stabilizer that's also an anti-epileptic drug is, you know, that it can serve many purposes, but its major purpose is to be a mood stabilizer. And even if it's acting as an anti-epileptic drug, you might need a couple of different drugs to do that, to really address the seizures and to address the mood stabilization features. A few words about stress and relapse. Everybody has stress reactions. Everybody has stress. Everybody can relapse to a previous level of functioning with any illness. So let's say you have somebody who's living in a group home, and let's say, for example, you have a young woman who has learned how to get all of the breakfast dishes into the dishwasher and has done a beautiful job at that, and has been quite proud of that accomplishment, that every single morning she takes care of all of the breakfast dishes and gets them into the dishwasher and stays in the kitchen until the cycle is completed, and then empties the dishwasher and puts everything away, and feels very good about that. And it took quite a long time to get that skill in place. But then her mother falls on the ice and breaks her leg, and so the mother is not able to visit once or twice a week as she had been. And that's very disruptive to the individual. So this young woman might not be able to do quite the level of breakfast dish clearing that she was doing before because she has an extra stressor. So anybody who's taught a coping skill or taught a skill in general needs to be able to anticipate, what am I going to do if there's a problem? And caretakers need to have in mind, what is this individual going to be able to do if they have an extra stressor? So teaching people how to pay attention to themselves is always a good skill. They need to know when they're starting to slip. Maybe their hygiene is slipping, or their interactions with others. They walk into a room, they walk into their workplace, or they walk into their workshop or into their program area, and they don't say hello when they walk in the room. Those kinds of slippages, they need to be able to say to themselves, oh yeah, I forgot to do that, or some kind of an awareness so that the individual can adjust when they know that they're being stressed, that they can still get some satisfaction from doing their previously learned skills. So everybody gets stress, and everybody will relapse to a previous level of functioning. And it's not by choice, but it's something that can be anticipated and can be prepared for. And the reason I bring it up is that any major mental illness layered on top of a developmental disability is going to have stress associated with it. And that's why we're going to talk about stress and anxiety and the medications that we use to address stress and anxiety. Certainly anxiety disorders can exist on their own, but anxiety is also a normal feature of who we are as human beings. We do have anxious circumstances. And anxiety at low to moderate levels, at that blue bar on the graph, is motivating and instructive, and it gives you cues to your environment. You wake up in the morning and you think, well, where am I supposed to be today? And what am I doing? And is my cell phone charged? And do I have my bus card with me? And what time is it? And there's just little things that can promote some anxiety. But it's not destructive, it's instructive. So you look at the clock and you see that you got up 10 minutes later than you're supposed to, well, then you're going to move it. You're going to move a little faster so that you're not going to be late. And it's going to give you cues to your environment because you're going to be a little bit more sensitive to what's going on. But when anxiety passes that moderate level, that pink bar, then you're not going to be absorbing information quite as well. High levels of anxiety usually interfere with functioning. And extreme anxiety is not motivating at all. As a matter of fact, people become immobilized, or they don't know how to learn at that point. They can't absorb information and process it, or they retreat back to a very primitive way of being. And that's somehow where fight, flight, or freeze comes in. Usually we hear fight or flight, but fight, flight, or freeze is more properly describing what can happen when someone has an extreme feeling of anxiety. They just freeze up, they lock up, or they run away, or they just fight, they scream, they have some kind of an interaction that is at a much lower level of functioning. And that's something to be paid attention to, because anxiety is a normal part of our lives. Extreme anxiety is not a normal part of our lives. So there has to be a sensitivity to the particular level of anxiety that's going to be produced. So, and what are you going to do about it? So you have to have an awareness and a certain ability to gauge what the person is experiencing. And some people with developmental disabilities are more than capable of understanding that. But people who are at higher levels of dysfunction are going to need somebody else in their environment to have that sensitivity for them. So when somebody is at a mild to moderate level of anxiety, that's usually someplace where we talk to people about how they can cope. If it's uncomfortable, if they're being affected in their functioning level to a certain extent, then you teach the individual how to cope, how to function. But when anxiety reaches those high levels, or the individual is not able to learn quickly enough to be able to manage the anxiety state, then you have to give anxiolytic medications, and that's another word for anti-anxiety meds. And anti-anxiety meds, very commonly, benzodiazepines, also called benzos. Valium, Librium, Ativan, Xanax, Versed. Well, you're not going to see too much Versed used recreationally, but you may have received it if you've ever had a colonoscopy. So there are medical uses for these things. And there are non-benzodiazepines such as Ambien and Sonata. The feature about anxiolytics is that each one of them has a slightly different side effect in addition to the main effect. Benzodiazepines like Valium will relax you. It'll take away your anxiety to a certain extent, and depending on the dose, it'll, could take the anxiety too low, because you need a certain amount of anxiety to be functional and to be motivated. But Valium also has an unusual feature that it can create a muscle relaxation in a certain set of muscles that have gone into spasm. So if you have a neck spasm, you have a stiff neck, you might be prescribed Valium for 2 days, because the side effect of the major calming feature of the benzodiazepine Valium is it releases the spasm just in the neck muscles. It doesn't do anything anyplace else. If you have a Charlie horse, if you have, like claudication, shin splints, something like that, it's not going to do anything. It might, but its claim to fame is you have a stiff neck, A couple of days of Valium will do it. And most of them have another feature to them. For example, Versed. Versed is given IV, intravenously. It's not a pill that you would take. But it is a benzodiazepine, and it is very anti-anxiety in its effect. Usually Versed is used when you're going to have a procedure done where they need you awake, but they don't want you upset. So if you're having a colonoscopy, for example, you've done the prep the day before and everything is cleaned out, hopefully cleaned out, and then they'll start an IV and they'll give you Versed. And the side effect of Versed, in addition to the main effect of anti-anxiety action, is that you are not able to create a new memory as long as Versed is active in your system. Now, there are always exceptions to this rule. I have known several people who have been given Versed and it didn't change their memory anagrams in a dot. They were totally remembering everything. But for the vast majority of people, Versed does take away the ability to create a new memory. So when you wake up from the Versed having worn off, you're like, when are we going to get started with this colonoscopy? And you'll be told, it's over. You can leave now. You know, have somebody drive you home. And you will not remember anything about that because you were not able to form a memory. But you were not upset while you were having your procedure done because it's an anti-anxiety benzodiazepine. Along a similar topic, non-benzodiazepines such as Ambien or Sonata, there are a number of them on the market, can create a sense of calm, but also there can be a psychological dependence. So even though Ambien is a non-benzodiazepine, it's usually used for sleep, it's a sedative hypnotic, you can start to tell yourself that you can't get to sleep unless you take your Ambien. And you start, as a cognitive behavioral framework, you start to believe that you need the Ambien in order to go to sleep. So while it's not as addictive as a benzodiazepine, it can be psychologically creating a dependency for you, so that's something to be kept in mind. But when people have a great deal of anxiety and they're just not able to learn anything new, they're certainly not going to be able to learn how to cope with their anxiety when their anxiety is super, super high. So we want the medication to bring the anxiety down to a low to moderate level. We do not want anti-anxiety medications to be given at such a dose that the person has zero anxiety, that they're totally calm and they're totally mellow, because then they're not motivated and they're not absorbing information from their environment. They're just chilling. They're having a fabulous time. Not all that useful. So in general in life, a low level of anxiety, stress, perfectly normal. From time to time, a moderate level of stress, you're going to have your performance evaluation at work, your teenager is learning how to drive, you're going for an interview someplace, you're going to have a medical test done. All of these things will raise your anxiety, but that is not a problem. It's not a problem level of anxiety. It's more motivating. If you're going to go for a medical procedure and your anxiety is up to the moderate level, you're going to be asking a lot of questions, and you're going to hopefully digest the answers. You're going to pay attention to what's going on, and you're going to, proceed. And the test will be over with, and your anxiety level will go down. It's when the anxiety level is very high that you are not going to be able to learn. And talk therapies will not be helpful for you at that point. And they would at the low to moderate levels. Cognitive behavioral therapy, even supportive psychotherapy, very useful in those frameworks, not at extreme levels. So the anti-anxiety medication that we are giving for people who are at high levels, there are a number of different ways of conceptualizing how these anxiolytics are to be used. In general, you want people, and anybody, in the general population, but especially people who have developmental disabilities, you want people to feel like they can cope to a certain extent. And the more coping you can help them to have, the better they feel about themselves. So being able to cope with even higher levels of anxiety is it's an important feature. So you take the medication at a high level of anxiety, and it prevents the individual from learning how to do anything for themselves except taking the pill. But that's all that can happen at that high level. You want to not give the medication on a PRN basis, on an as-needed basis. That tends to behaviorally reinforce issues about anxiety, because the person learns at high levels of anxiety that when I take a pill, I feel fabulous. So it doesn't really teach them how to take care of themselves. It teaches them how to take a pill. At very high levels, that needs to be done, but the dose needs to be such that the person still has some level of anxiety, which is motivating for them to learn how to cope. So you don't want to remove all of their anxiety with the dosage of the medication. It has to be at a certain place. And giving it as a regular dose instead of PRN tends to remove the classical conditioning that can take place if somebody complains about anxiety and then they get a pill that makes them feel fabulous. Then, then they're going to do that again and again and again. But there is a non-benzodiazepine Buspar, B-U-S-P-A-R, that you give 3, even 4 times a day because it has a very short half-life. And that stays in your system so that you are constantly having some protection against a high level of anxiety. And you have, I mean, it doesn't completely wipe you out. It's not a benzodiazepine. So the person is then able to continue to learn how to cope with what's going on. And it's important to teach people how to rely on themselves instead of relying on a medication. So having talked about schizophrenia, depression, bipolar disorder, and anxiety disorders, we didn't specify anxiety disorders, but you know what they are. Obsessive compulsive disorder is an anxiety disorder. Post-traumatic stress disorder is an anxiety disorder. Just generalized anxiety disorder is an anxiety disorder. Anxious feelings are endemic. We all have them, and it's what you're going to do about them that counts. So with those general diagnostic categories in mind, let's now talk about how do you overcome the communication barriers that can take place with people who have developmental disabilities, and they may or may not have all of these other features going on. And not surprisingly, some of the strategies are not pharmacological. They're behavioral and they're interactional. And they take a look at what the person is doing and how they're functioning in the world. There are a lot of ways to overcome barriers, and it doesn't involve giving somebody an additional medication. So let's talk about routines. Anybody who has a developmental disability needs a certain structure to their life, and sometimes that structure is overwhelming. It's way too structured, and they can't deal with anything being a little off their structure. But one of the issues that people frequently ask me about is, what do I do with somebody when their schedule has to change? Let's say somebody has moved from one residence to another residence, and it's a little farther away from their program area, or their family members have to come at a certain different time. So let's say, for example, the one I have up here is that the person has to wake up earlier, and that's very disruptive for the individual. And you can substitute waking up earlier for any other issue that would be difficult. But for many people who have any developmental disability, it's important that they have a morning routine. All of us have morning routines. And it can reduce some of the challenging mornings, some of the more difficult, stressful aspects to a change in their lives. So I have an example here. If Joshua's been in the habit of eating breakfast in his pajamas and watching his favorite television show for an hour before he gets dressed, but then he moves to another residence after he's been there for 2 or 3 years, and now his routine is very different. How do we manage that? How do we take care of Joshua so that it's not so difficult for him to make this change? One of the things that you can do is to start early with making this routine change. So even while he is in his previous residence, if you have the luxury of figuring out what to do with these things, you can start adjusting and molding his routine weeks ahead of time. So it doesn't have to be done all at once. Let's say, for example, he has to change an hour of watching TV to 15 minutes. And you've got 2 months to do that. So every single day, you move it up so that he's sitting there watching TV for several less minutes. And several less minutes, and it depends on the individual. You know, for Joshua, it was better to do a chunk of like 10 minutes and then leave him there for 3 or 4 days and let him get used to it, and then do another chunk of 10 minutes and leave him there. And so that was his routine for a week or so, sometimes even a couple weeks. And that helps. On the other hand, you might have people who become so disrupted that it's better just to get them all adjusted all at once. So you do it very quickly. And you have to know your clients very well, and you have to do what's best for them in coping and in managing. And routine changes can be difficult. And it can be something as simple as somebody has moved out of the group home and another person has moved in. And that other person who moved in is different in a significant way. Or I had one residence that it is originally a group home, a large-sized group home. They had obviously last decorated the place in the 60s, and so the walls were all painted this avocado green, which is actually by itself not a bad color, but it was really out of style for quite a long time. And so they came in and they repainted, and they painted all the rooms this beige, eggshell, tan, you know, something in that range. And it was very disruptive to some of the people who lived there because it was a different color, and they couldn't get away from it. Where was the color they were used to? So it's good to try to help people to cope, to adjust to something that's different. And getting a different routine around it can help. This doesn't show up very well, but in quieting the storm, when somebody is disrupted, somebody who has a developmental disability, it can be uproarious for them, what's going on in their minds about what is happening in their quality of life. And that disruption is, it's a theft of something that's very important to them. And you want to be able to give them back some quiet time. So even if they're very disrupted by their routine being changed, sometimes you can get a quiet activity at a specific time and place, and you routinize that particular thing, just enough to hold them over so that it has the intention of providing a special experience for them. It uses whatever they were really good at before. If they were really good at playing cards, then try to shape something around card playing. If they really like writing in their journal or drawing or coloring or crossword puzzles or word find, and whatever the activity was that they were good at, put that back into place, but in a small little compartmentalization of time so that they can feel the difference. That here's this disrupted routine, and here's this special routine that I have every single day. And it's not required that it be done in exactly the same way every single time, but that it has the feature of being quiet and it's calming to somebody who's been very disruptive. So, communicating and motivating. I did not specifically talk about post-traumatic stress disorder as anything as a standalone, and I just mentioned it as an anxiety disorder. But when somebody who has a developmental disability also has post-traumatic stress disorder, which is extraordinarily common, given how many people brutalize or just abuse people who have DD, it is very common to have communication and motivation problems that will raise. It'll raise the specter in your clinical care. So keeping that in mind, this is true for any situation where you have communication and motivation foci that need to be paid attention to. So one way to do that is to use, and these are just examples, use an external motivation system. in order to get the person to communicate and to get the person to motivate. Let's say somebody really likes to go to a certain coffee shop and have coffee. And if you want them to do something like go to their sister's graduation, you can say, I'd like you to go to the graduation, and after that we can go to this particular coffee shop. That would be a really good way for you to externally motivate the individual. On the other hand, if you have somebody who's internally motivated to go to their sister's graduation, you don't need to have an external motivation system in place. But many times you will have to have some idea about what could be put from the outside into this individual so that they can feel like they'd like to get going on something. So when you are using an external motivator, and I have a list of some examples here, and I'm sure you have several more, watching a particular TV show, playing a favorite game, running an errand to a favorite store, points and tokens in certain token economies are exchangeable for something that she or he wants. But remember, the motivation has to be powerful, and it has to be immediate. It can't be later, like months down the line or even days down the line, because that won't really work. You need to have a powerful reinforcer for that individual. Like for me, popcorn is not really going to be a very powerful motivator. But for somebody who loves popcorn, oh, that could very well be the ticket to what you want to be doing. So you have to individualize it, and you have to pay attention to what motivates that individual. What would be a powerful draw for helping them to get done what needs to get done. And of course the immediacy is important, especially if they have attention issues. Just as an issue of clothes, many times people with developmental disabilities, autism in particular, anywhere on the autism spectrum can have issues about tactile sensations and sensory integration issues. And I've had any number of clients who will only wear a certain item of clothing. And so when you find that item of clothing, you buy 10 of them. But a little tip from hard-earned experience, when you buy 10, let's say, of a certain shirt, have them try on all 10 shirts if you can get that done. Because it might be that one of them is milled in a particularly different way, or that the seam is a little off-kilter, and that can be very distressing. So you want there to be an acknowledgement of what's going on with their clothing, but also you want to make it as easy as possible for them to be able to function around clothing. So give the person who has a developmental disability time to get used to wearing new clothes if something has to be done. In some cases, wash them several times. And if you use a fabric softener, use one that doesn't have a fragrance to it. That tends to be universal, as that people don't like the aromas that people are attaching to certain products. Plan wearing the new clothes for gradually longer periods of time and not before a major event. So you don't take the brand new shirt and put it on just before they're supposed to go to their sister's wedding, because they might be uncomfortable and they might be reaching and scratching and pulling and just restlessness around this new piece of clothing that they're just not used to. It might be a perfectly appropriate piece of clothing, but they don't need the extra burden of having to wear this piece of clothing in a social setting. So gradually plan ahead of time. When you're having an active relationship with people who have developmental disabilities, you want to have a good relationship, of course, with them. You're a service provider, you're taking care of somebody, you have expertise in a particular area. Wonderful that you have chosen this population to put your energies into and to give them a better quality of life. But that's not the only person you have to have a good relationship with. You have to have a good relationship with people in their world who are important to them. Family members, friends, landladies, other residents, you need to have a stage set for having a good relationship. So in general, consider how having a flexible attitude on your part, and I'm not talking you have no standards, no boundaries whatsoever, that would be the extreme, but also not to be totally rigid either, but to have a flexible attitude can make everything that you do, every task and every issue, run a lot more smoothly. So take a look at the last 2 struggles you had with somebody who has a developmental disability and see if maybe what's going on is it was a control issue, a power issue of some kind, and that there needs to be some kind of a relaxed attitude. So let's say, for example, you want a recipient of your care to do something in a particular way, and they are resisting having your assistance. They're just digging in their feet, and they're saying, absolutely no, I'm not going to do that. So one way to do it is just to be a bulldog and bulldozer and just go and force your way into the situation. But remember, a little bit of flexibility on your part can go a long way. So another way to handle it, and you might have had great success at doing that, at being a bulldozer and getting things done. And I have seen many cases where people do respond to that level of intense direction. But consider distracting the individual with something they like to do, and then slowly reintroducing the assistance towards the intended goal. And by slowly, I mean it's not going to be on your timetable. It needs to be on a different timetable. It doesn't have to be on no timetable whatsoever, and that things are completely laissez-faire. You'd never get your work done. But if you distract, pull that emotional energy away from that situation just for a few moments, you'll notice that you're able to come up with more ideas about how to handle the situation. And you might be surprised and find that the individual is much more cooperative. So distract and then slowly reintroduce whatever it is that you were trying to do. A little flexibility goes a long way. You don't have to be Gumby, but you do have to have, you know, some movement to you. In general, when you're dealing with people who have developmental disabilities and their family and their friends and people in their environment, you need to have some positive experiences, but they might not happen spontaneously. If they do, great, more power to you. But planning for some positive experiences is a very powerful thing to do. So prior to starting anything new, let's say in a social situation like what's up on the slide, target 1 or 2 people who will be involved in that social activity with the person who has developmental disabilities. And usually, one person at a time is easy to deal with than a whole group. Planning a relaxing adult day. That's what we're having. Aren't we having a relaxing adult day? People who have developmental disabilities need an advocate. We all could use an advocate for various aspects of our lives. But somebody who has a developmental disability has a different set of things to deal with. The factors that are controlling whether they feel productive and whether they have a good life or not are much more challenging than the ones that we have. And advocacy is never ending. It goes on as long as you have that relationship with that individual. So teaching is a major component of relaxation. You're teaching somebody how to deal with their stress. But you're also teaching yourself how to deal with the stress of the person who has a developmental disability. You have to take care of your own needs in order to have the time and energy to deal with others. It's like when you go on an airplane and they tell you, they go through the safety briefing, and they tell you what to do when the oxygen mask falls out of the compartment. They say, you must put your own oxygen mask on before you go to help somebody else, like a child or an older person. Because, as you can imagine, if you needed oxygen and you were struggling to get the oxygen mask on a child or on somebody who needed help, and you didn't have your own oxygen level that you were paying attention to, you're going to pass out, and then you're going to be of no use to anybody. And if you didn't finish getting everybody else ready, then they're not going to get ready. So you have to take care of yourself. And the exact same thing happens when you're dealing with people who have developmental disabilities. It's a very specialized population, and you have wonderful special skills in order to deal with this population, in order to contribute to the quality of their lives, in order to help them to cope and help them get through their day. But you need to take care of your day and your coping as well. Otherwise, you will not be of much use to everybody else you're trying to work with. So what we've covered, despite the fact that you can't see me, is the discussion about the common presentations of people who have developmental disabilities with certain comorbidities. The assessment strategies, we're always assessing, all the time. We can't not assess. And depending on our professional activities, we know that assessment is a constant with us. We talked briefly about the typical medications, what's taken with comorbidities and how to pay attention to the main effects of medication. But the more practical aspect to keep in mind is, with these typical medications, what are the side effects like? We talked about the side effects of the medications for major mental illnesses, and that can be extrapyramidal side effects, which are very uncomfortable. And if you're taking a medication that makes you very uncomfortable, chances are you're going to stop taking it, or you're going to take it inconsistently, which will not help you very much. So the main effect of the medication is certainly something to keep in mind, as is the side effect. And sometimes we can very effectively use the side effects. If somebody's, for example, having trouble sleeping and we're giving them a mood stabilizer that's sedating, all the better. One less med you have to give them. Give them medication at bedtime, and then they're sleepy when it's time to be going to sleep. And then we talked about communication tools, about how it's important to have a plan and a strategy and the time to do it. Sometimes we don't have the luxury. One place closes, another place opens. You've got to jerry-rig things. But when you have it, it's nice to be able to talk about how things can be done in a very effective way. And in general, coping with resistance to assessment and treatment is use the knowledge you have of the individuals you work with. Are they distractible? Do they have things they really like to do? Use it as motivators. Use it as something that's going to reinforce where they're going and the goals that they have for themselves and the goals that their family and loved ones have for them. So we need to keep in mind that just because somebody is resistant doesn't mean that that's the end of the road for us. Distraction can be enormously helpful in that regard. So after the going over all the content of today's presentation, we have some poll questions for you. And well, they're on the PowerPoint, but they're also going to pop up in terms of you answering them. So the first question is, one of your recipients, who's always been self-stimulating, begins to significantly scratch and cut herself as well. What could this mean? The recipient is having emotional problems. The recipient may have a new physical complaint. The recipient's blood pressure has changed. The recipient's medication need to have a GDR, the gradual dose reduction. The correct answer is A and B. Number one, which is the recipient's having an emotional problem. I mean, the self-stimulating is an ongoing feature, but to significantly scratch and cut herself could be having an emotional problem, could be having a new physical complaint. You know that dermatological problems with people who have developmental disabilities is far-reaching, and there are many, many issues around eczema and psoriasis that can make somebody scratch. And it might not be self-injurious behavior. It might look like self-injurious behavior, which certainly would be an emotional problem. But also take a look at the physical complaint. Poll question 2. Assessment of a newly admitted recipient with developmental disabilities takes into consideration the recipient's communication skills. How are they talking? How are they indicating? Even if they're selectively mute or really mute, not able to speak, what are they communicating? Are they showing preferences? Are they showing dislikes or appreciation for things? What's their functional level? What are they able to get done? What's their living environment? Are they living at home with elderly parents who have Parkinson's disorder, and one has Parkinson's and the other one is struggling to try to deal with the child who has autism and the husband who has Parkinson's? You know, what's going on in their environment? What's being talked about? What's being done? How are they eating? How are they sleeping? And what's their physical status? You know, how are they doing? Do they have comorbidities? Are they very constipated? Do they have a lot of urinary tract infections? Do they have rashes? And of these choices that you have, the correct answer is all of the above, number 4. All of these things need to be taken into consideration. And not all of them are going to be addressed practically with pharmacology. We certainly need to have pharmacology on hand, but when we're dealing with the practical issues of people who have comorbidities, including a developmental disability, we need to take all of this into account and try to work it into a program that's going to be best for that individual. Poll question 3. You are conducting a group with 5 recipients who have developmental disabilities, and one recipient suddenly and for the first time is screaming and acting out and aggressive. The most likely explanation could be this person has dementia, or this person has an infection, or this person is having a reaction to the environment in some way, or D, they're having an allergic reaction to something. So you see the choices there. The first choice is that the person has an infection of some kind and they're reacting to the environment. The second choice is that they're reacting to the environment. The third choice is that they're obviously demented. They're having some dementing process go on. And the fourth choice is that all of these things need to be taken into consideration as an explanation. And the correct answer is number 2. Something's going on in the environment. All of a sudden, this person is screaming, acting out, and aggressive and has never done this before. Something's going on in the environment. And you need to look distally, like what's happening. Is the room too cold? Is there somebody out in the hall who's slamming their door over and over again? Is it the ice cream truck is making its little sound and they want to get out there and they can't get out there because they're in group, and so they're very agitated. What's going on in the distal environment? And then bring your observations in closer to what's going on with the group, the interactions with the other people in the group, or the environment in terms of, you know, are they sitting in an uncomfortable chair? Is their clothing suddenly a problem in some way, that a zipper has broken, or a hook and eye is digging into them in some way? So the environment, whether it's distal or proximal, needs to be taken into account. The poll question number 4. When giving directions to recipients with developmental disabilities and they resist assistance, repeat what they should be doing until they comply. Just keep repeating it over and over and over again. Or distract with something they like to do, then slowly reintroduce assistance. Or express approval verbally and with appropriate facial expressions. Or carefully explain 3 problems with what they're doing. And you can't make this stuff up. I've actually had people tell me all of these as a response to when somebody is resisting assistance. But the correct answer is 2. Distract with something they like to do and then slowly reintroduce assistance. You don't have to push. You don't have to get into control struggles. You don't have to totally ignore the issue and do something else, and you don't have to overwhelm them with cognitive information, like carefully explaining 3 problems with what they're doing. So in general, you want somebody who has a developmental disability to feel like they can interact with you as a human being, and that you're not completely rigid, and also somebody who has absolutely no structure whatsoever to what's going on. So you have to find a middle ground, and you also have to know your recipient. And the last poll question is regarding medications commonly used for people with developmental disabilities. There are a variety of medications specifically indicated for the treatment of developmental disabilities. B, medications treat the various symptoms but are not indicated for the disability. C, indications are not relevant when discussing medication. And D, no medications are commonly used exclusively for those with developmental disabilities. And the choices you have there are A and B, C and D together, and D by itself. And the answer is number 2, which is B. Medications can treat the various symptoms of a developmental disability, but there is no medication that we can give to somebody to treat that developmental disability, to make their cognitive functioning increase in that very specific way. There is no medication for Down syndrome. There is no medication for Syndrome X. There is no, or Fragile X syndrome, I should say. There is no medication specifically for developmental disabilities. But if they're having different symptoms, if they're having trouble coping, then we can bring their anxiety level down with a medication that will help them to be able to learn how to cope a little bit better. If they're depressed, we certainly have medication that can treat a depressive episode, etc. So even though there is not a specific medication for a developmental disability, we do give, as you know, a great deal of medications. So I finished a little earlier than I had planned. I probably talked way too fast at the beginning, but you're going to have a survey that'll pop up on your internet browser, and if anybody doesn't see that survey, then you're going to be sent an email tomorrow, and there'll be a link in there, and so please follow that link, and you'll be able to answer the survey that way. And we really do appreciate your feedback. It's extraordinarily helpful to us, because this is supposed to make your work life and your experiences with people who have developmental disabilities better.